All right, welcome back everybody. So in this video, we are now going to talk about metabolic alkalosis. Remember our terminology here. Alkalosis is a process by which we create an alkaline state versus alkalemia is an overall change in our pH. So somebody who has an alkalemia might have a pH that is 7.47, 7.5, anything above our reference range of 7.45. So first let's look at the primary mechanism here. We said that we have an increased pH due to either a decrease in protons and or an increase in bicarbonate. This should make sense to you, right? We know our protons create an acidic state. So anything that's going to cause us to lose protons or cause us to have a decrease in protons is ultimately going to raise the pH. This is something that students often know, they understand at baseline, but then when they get into a question, they rush through it quickly and they think, oh, a higher pH means a higher protons. No. Don't make that mistake. Think about it for a second. Say higher pH would have less protons. Also, you could have an increase in your bicarbonate level. Remember, I told you all to associate our protons with an acidic form or an acidic environment and to associate our bicarbonate with a basic form or a basic environment. So if we have more bicarb, we have more base, that's going to cause more of an alkalosis. So if we look at our table over here in the corner, we see that we have an increased pH, which makes sense, and that our primary disorder could be due to the increased bicarb or decrease in hydrogen protons. We can also see that as a compensation, our PCO2 would increase. And I'm highlighting that here in green, an increased PCO2 for compensation. And let's think about why that makes sense. Remember, we previously talked about the relationship between hydrogen protons and CO2 in the body and how the equations shift towards more hydrogen protons or away from hydrogen protons depending on our ventilation and how much PCO2 we actually have in our system. So if we increase our PCO2, we are slowing down our breathing. We are decreasing the amount of CO2 we're offloading. That's what's creating this elevated PCO2. And this is important, right? Because this is going to favor more hydrogen proton formation. It's going to shift our equation towards the formation of more hydrogen protons. This is helpful for balancing out the body and returning to homeostasis because in this condition, in a metabolic alkalosis, our pH is too high. We want to balance that by bringing it down to a normal level. And so by creating more protons, or in this case, increasing our PCO2 so that we ultimately increase our proton levels, this is going to attempt to bring us back within our normal pH range. So now let's talk about some common causes that can cause a metabolic alkalosis. Notice I've broken it up into two categories here. We have chloride responsive, which would have a normal urinary chloride, and chloride resistant, which would have an increased urinary chloride. Why does this matter? This matters because it helps us think about what are the treatment options that we have. Things that are chloride responsive are going to improve if we give the patient sodium chloride, NaCl. However, causes that are chloride resistant are not going to improve if we give them an administration of NaCl. This matters because the primary treatment option for treating a metabolic alkalosis is to treat the underlying cause. And so we need to know, is the underlying cause able and willing to resolve or improve with sodium chloride, or if it's not, then we need to think about what are the options that we have for this patient. So a general rule of thumb is that things that are chloride responsive are conditions that are due to a loss of protons or hydrogen ions, and things that are chloride resistant are more so due to an increase or a retention in bicarbonate in the body. So if it is a condition that can be resolved with sodium chloride administration, we say that is chloride responsive. Some examples include hypovolemia, loop or thiazide diuretics, as well as vomiting or gastric suctioning. So let's walk through each of these. Anytime we say we have a volume contraction alkalosis, which is what we're saying for low volume levels, indicates a particular process is occurring. A contraction alkalosis refers to a process that causes an increase in our serum pH due to a loss of volume. So you can imagine that hypovolemia or low volume states or an overdose or too much thiazide or loop diuretics can cause this low volume. But how does this process work? While the process is not entirely understood, one that should make sense to us and can be appreciated is this idea of thinking about our volume contraction and how it affects other areas of the body in terms of compensation. So let's look at the example on the bottom here. Let's say we have a certain amount of volume in the body, which I'm highlighting in blue, takes up this much space. And we have a process that allows us to lose some of that volume, and now we have only this amount over here. Let's think about what is the body going to do in a state of low volume level? What are our typical compensatory responses? Well, from previous videos, we know that one of the primary ways our body responds to low volume levels is to activate the renin-angiotensin-aldosterone system. And that's what it's going to do here. It's going to activate that system and cause a release of more renin. So you can see here we have an increased renin, which will then lead to an increase in angiotensin 2, which will then lead to an increase in aldosterone. And remember back, what are the primary things that aldosterone is going to do? One, it's going to work to increase our sodium levels because we know that water follows sodium. If we bring back our sodium, it's going to bring back some water and potentially restore that level of fluid that we've lost. But what is the price of that? What is the cost of bringing back our sodium? We talked about in our nephron transporter series all the different effects that aldosterone can have in terms of which pumps it stimulates and its overall goal, which again is to bring back sodium. However, bringing back the sodium comes at the loss of hydrogen protons and potassium. And so if we are secreting more hydrogen protons in an effort to bring back more sodium, this is going to contribute to our alkalotic state. We are losing our acid. We are losing our protons. This contributes to our metabolic alkalosis. It's also worth noting that a lot of times these patients end up with hypokalemia as well because, again, this loss of potassium ions. So when we say somebody has a contraction alkalosis, it's that they're losing volume, but the downstream effects of activating the RAS system and how that plays in with the nephron transporters causes the patient to have some additional complications, such as worsening alkalemia, also hypokalemia. And an additional point that contributes to this contraction alkalosis is the fact that angiotensin II stimulates our sodium hydrogen exchanger in the proximal convoluted tubule. And so ultimately this process increases hydrogen excretion, which then leads to an increase in bicarbonate reabsorption in the body. So there are several mechanisms that you can see. The primary stimulus is a low volume level, and then the body's stimulation of the RAS system contributes to the ultimate effects. With arthritic vomiting or gastric suctioning, this should make a little bit more intuitive sense. If you vomit, you're losing a lot of hydrogen chloride as well as potassium, which is in our gastric secretions as well. And if you decrease these, this is going to decrease our proton levels, right? Because we're losing our hydrogen, part of our HCl, and this can ultimately cause an alkalotic. Key here I want you to be mindful of is that these patients can also present with hypokalemia, which I will highlight here. So next, let's talk about chloride-resistant causes. First, we have hyperaldosteronism, renal tubular defects, and also loop or thiazide diuretics. For our hyperaldosteronism, it's the increased secretion of hydrogen protons. Remember back to our image of the collecting duct. Aldosterone stimulates many different channels. We know it stimulates the ENaC channel, the sodium-potassium pump, and it also acts on our mineralocorticoid receptors to increase protein synthesis. And we previously talked about how stimulating this ENaC channel right here causes more sodium to go inside of the cell, which creates something called lumen negativity out here in the tubule. Well, ultimately what that does is it affects the alpha intercalated cell's hydrogen proton ATPase and increases the rate at which it works. So stimulating the hydrogen ATPase causes more hydrogen protons to go out into the tubule, which is our positive charged protons or things that contribute to an acidic state. So if we're causing secretion of more of them and then ultimately excretion out in the urine, this is another way that's going to contribute to our alkalosis or our alkalotic state. Next, there are several renal tubular defects that can cause this presentation as well. And the primary reason is that each of these in their own way cause a decrease in sodium reabsorption. This decrease in sodium reabsorption can ultimately cause a volume contraction alkalosis. So again, the ones that can cause this are Bartter syndrome, Gittleman syndrome, and Little syndrome, in addition to apparent mineralocorticoid excess. But the one that does not cause this condition is Fanconi syndrome. And the reason is because the problem in Fanconi syndrome is notably different than it is in these other conditions. Do you remember what Fanconi syndrome was? That's right. It's a generalized reabsorption defect in the proximal convoluted tubule that can cause patients to excrete too much of their bicarb and glucose and amino acids or otherwise molecules that we would typically want to retain, but there's a defect in the ability to do so. And finally, we see loop and thiazide diuretics again causing a volume contraction alkalosis here. So this is a tricky one, right? Because this can result in either a chloride responsive or a chloride resistant pathophysiology.